Taenia Solium or pork tapeworm infection and cysticercosis, a brief talk for medical students by Sanjeev Bagga, MBBS, MS Surgery, Diplomate of American Board of Radiology and Nuclear Medicine. Taenia Solium infection results from eating contaminated pork. Cysticercosis is infection with larvae of Taenia Solium, which develops after ingestion of ova excreted in the human feces. Cysticercosis may manifest without any symptoms when larvae invade the central nervous system. Neurocysticercosis develops. Seizures and other neurological signs develop. Diagnosis of neurocysticercosis is usually made by a CAT scan or MRI. Less than 50% of patients with neurocysticercosis have adult T solium in their intestines and thus eggs or proglottids in their stool. Humans infected with adult T. solium worms have mild gastrointestinal symptoms or no complaints. Proglottids may be present in their stool. Neurocysticercosis develops after the ingestion of eggs from the feces of a tapeworm carrier, i.e., fecal oral contamination. Neurocysticercosis may cause symptoms due to mass effect and inflammation induced by cysticerci. Patients may present with seizures, signs of increased intracranial pressure, hydrocephalus, focal neurological signs, altered mental status, or aseptic meningitis. Cysticerci may also infect the spinal cord, muscles, subcutaneous tissues, and the eyes. Diagnosis can be established by microscopic examination of the stool for ova and proglottids, CT and/or MRI, and serological tests for patients with CNS symptoms. Cysticercosis can affect any organ. The most common sites of involvement are the central nervous system, subarachnoid spaces, ventricle, spinal cord, eye, and muscles. The right CT scan image demonstrates lesions involving both the cerebral hemispheres with associated edema. Neurocysticercosis has been classified into active and non-active forms based on the clinical presentation result of CSF analysis, which shows low CSF glucose and eosinophils in the sediment, cysticercus specific immunoglobulin G antibody level. Imaging findings: the active form include arachnoiditis with or without ventricular obstruction, vasculitis with or without infarction. The CT scan demonstrates extensive calcified lesions in the brain. On the basis of radiological finding, neurocysticercosis is divided into 5 stages, namely non-cystic, which is often invisible, vesicular 10 to 20 millimeter cysts are seen with signal intensity like CSF on MRI, colloidal vesicular, where the cysts have proteinaceous material and they are bright on T1 and T2 weighted images on MRI with enhancement and edema around it, granular nodular, which are similar to colloidal vesicular with more enhancement and edema, and calcified nodular, which are calcified lesions with low signal, which are dark on MRI with no edema or enhancement. The corresponding MRI on the right demonstrates multiple high signal T2 weighted disseminated lesions of neurocysticercosis. Treatment of neurocysticercosis involves anti-epileptic drugs and cysticidal agents like albendazole, praziquantel, corticosteroids, anti-inflammatory agents used to control potentially harmful host inflammatory response. Another choice is to give 2 grams of niclosamide, which is given as 4 500 milligram tablets that are chewed one at a time and swallowed with a small amount of water.